Hoeffler, and I am the manager of crisis services for the Office of Behavioral Health. And just to tell you a little bit about where I come from, I spent 9 years prior to coming to the state last year with the University of Colorado Hospital. I worked in the ER doing psych and trauma. So that was really my background. And prior to that, I had worked in San Francisco for close to 18 years, really in all aspects of service delivery of behavioral health care. From addiction medicine to assertive community treatment. I worked for the city and county of San Francisco for a while. So really, not specifically with adolescents and kids, primarily with adults and families, but so kind of all aspects of what things look like in behavioral health care. So I came about because of Bill 13266, and I don't know how familiar you guys are with this bill, but as Liz said, it came out of a governor's initiative. Back in 2013, he convened a group of folks to really take a look at what our crisis response system is like in Colorado. And I can say this somewhat lovingly, but Colorado is terrible. It has historically been terrible in funding for people with behavioral health care issues. We have typically ranked in the lower 48. So that has been terrible. So 47th, 48th, 49th as far as funding for people with behavioral health problems. So back in 2013, really on the tail of the Aurora Theater shootings and also just the mental health, behavioral health system in the state, a group got together to really take a look at what exists, what works, what's not working, and where we need to really focus on. So WICHE put out a report that took an inventory of services. So what we have in the state of Colorado are 17 mental health centers, 7 specialty clinics, about 331 licensed substance use disorder services, along with 14 different crisis lines. So if you're a consumer in crisis or a parent of someone who's having an issue and you Google or look at crisis lines, there are 14 or 15 different numbers. So the reason that is all the mental health centers maintain an after-hours crisis number, but they close for holidays and for retreats, and after hours they're not open. So the ER has always been the default to that. Certainly there's national lines that get routed to different hotlines, but there wasn't really one central crisis line. So that is what we found out. We also found out, and you guys might know this, but 73% of our counties in the state are rural and frontier. So if you live between, I like to say, Pueblo and Alamosa, it's really pretty. There's not a lot out there for you. So you're having an issue and you live somewhere on that road, it is far away to get to Pueblo, or if you're in Durango, where do you go? Yes, there's mental health centers, but really the crisis component was not really there. So, and I will talk a little bit more about what that group came up with. But just to talk about, so 13266 is about $25.5 million that was appropriated for crisis response. And I say this sort of off the top, just to say it doesn't solve the homeless problem in the state of Colorado, doesn't create housing for homeless families, it doesn't make us have more psychiatrists that can see someone in a week. So, and I don't mean to be like negative Nancy, it's just not enough money to do that. So $25.5 million comes out of general funds, so we don't have to go back to the legislature every year and beg, but we also know that that's not enough money to create this really nice, seamless, no wrong door system. So when this group convened, they also tried to look at where in this country is this happening well. So, and I always say, you know, I don't know that Texas does a whole lot right, but they really did their redesign. Their crisis redesign is remarkable. It's this very integrated system between providers, case managers, law enforcement, first responders, and it's a very well-oiled machine at this point. Their first year, they were funded probably a little under $83 million. So I know that Texas is a lot bigger than Colorado, but again, if you look at 73% of counties are rural and frontier, what happens to those folks that are not living in the 7-county sort of I-25 corridor? So $25.5 million is a really good place to start. We all know that it likely would need more money to really beef up training, pay clinicians a better wage so they don't leave once they're licensed, et cetera, et cetera. So, and that's true. I mean, I'm aware of what they're paying clinicians, and you know, you need to hire licensed clinicians, and you want people with experience, but you can't do it. So people get licensed, do that, and then leave elsewhere. So we really want to look at making sure to retain talent and people that have the skills that we need. The other thing, and this pertains certainly to TBI and head injury and other physical issues and that show up along with behavioral health issues, they also looked at, over the course of 10 years, certainly there's been an increase in licensed clinicians in the state of Colorado in the area of just sort of general mental health and substance use, but not enough clinicians to possibly deal with people that have multiple diagnoses. You're talking about someone with PTSD, TBI, maybe an alcohol problem. So these complicated, polydiagnosed folks that have multiple issues, not like the worried well. So yes, there's probably lots of therapists to see many of us in here as kind of the worried well and help me figure out my coping skills. But when you're looking at people that have multiple issues, family, health, not just behavioral health, there's not enough clinicians. Did you have a question?
Yeah, I do. And if you wouldn't mind repeating the question, because that's the only
okay.
You had mentioned that there were all these other phone numbers.
Yes.
Are they being rerouted, or were they shut off, or how do they?
No, very good question. So you know, ideally, the state would love to have one phone number. But as we know, change is difficult. People hold on to things that they know. So for example, all the mental health centers have these after-hour numbers. And if you've been a consumer at a center for 20 years, you know that number. And you're going to hold on to that number. So the state has not forced out any of these phone numbers. Of course, if it was up to me, I'd say by this year, we need to really educate the communities and consumers that this is the number you call. Because what happens is, you call after 5 o'clock or when they're closed for a long weekend, people get frustrated. You don't want to leave a message. And so what I say is the hotline, you don't leave a message. It's a 22-second outgoing message. There's a clinician on the other line. But again, change, as we know, is hard because this is something you know. Yes?
Are you linked in with the suicide hotline?
No, it's a separate thing. So you're talking about the National Lifeline? Yeah, that is a separate thing. So this is just unique to Colorado. This 844 number is just unique from this project. So what the legislation created, after looking at, Georgia does a phenomenal hotline call system as well. So they looked at states that have crisis services, that have been doing it well, that have been doing it for a while. So it created a 24-hour statewide hotline. Again, we know that there's lots and lots of phone numbers, but this is the one we're trying to encourage people to use, because there are no, we're closed today because of a retreat, we're out to lunch, none of that. And you don't leave a message. So it created a hotline and warm line. So the hotline is answered 24 hours a day, 7 days a week by master's and doctorate level clinicians. Some of them licensed, some of them on the way to licensure. The warm line is currently answered from 9 a.m. to 11 p.m. and those lines are answered by peer specialists. So people with lived experience that have some recovery around their mental health issue, their substance use issue, whatever it is that they come to the table with. The hotline folks, so Rocky Mountain Crisis Partners, who operates the hotline, they do not train peer specialists. There's multiple organizations in the state of Colorado that will train peers to do this kind of work. These are paid positions, these are benefited positions, they're part of the clinical staff, and it has been a gift, I will tell you. Peers are used throughout all aspects of service delivery for crisis, and there has been no lack of peer specialists interested in these jobs. Unlike, we're looking for nurses, we're looking for licensed clinicians, so peers have really stepped up, and when I've been able to be on site, the feedback from peers has been remarkable, because they can help navigate some things. And recently I was at Victor Street, and the peer specialist that is there is knows Medicaid better than probably anyone with a master's degree, is what she said. And that's probably true. So she could help a consumer, their family member, kind of navigate that system, because we all know how frustrating that can be around getting services. So when the hotline first opened on August 1st, they became operational August 1. They were answering about 180 to 185 calls a day. After Robin Williams completed suicide, those calls spiked to about 330, 335 a day for about 3 days. Last count, sort of December, there's current data as well, but they were answering about 220, 225 a day. The warm line staff were answering 30% of the calls and managing 30% of those callers' needs. And that's what the goal was, to see if 30% of the volume could be managed by the peer specialists. So just to say this, the state obviously asks for lots of data from the contractors for lots of reasons. But I want to reassure you guys, when you go out and talk about this, or you know people that want to use this, we do not have access to clinical information. The state gets some basic information about volume of call, length of call, type of call, what the concern is, and then call outcome. We get some basic demographics. But those clinicians that are answering the phone will make a note regarding what that call's about, because likely they may be a repeat caller, so the next clinician can pull up that information and not start from the beginning. Yes?
I just have a question about, it's one phone number.
Yes.
But sort of two lines.
Yes.
Is it sort of triaged? Or
Here's the, so it's a 22-second message. Good question. And I usually don't forget this. So if you want to speak to a peer specialist, you hit pound or hashtag, and it'll tell you that. It'll say something like, you've reached the Colorado Crisis and Support line, stay on the line to speak with a trained clinician or whatever they say, or hit the pound sign to speak with a peer specialist. That outgoing message is 22 seconds. So we have to really educate people, this is not a voicemail. It's not going to keep looping. You know how sometimes you hear that saying, you're on the phone waiting for Chase Bank to pick up or whatever, it goes over, have a good day, whatever. So this is not like that. It goes out once and a clinician will answer the phone. But people have to listen to that whole message or they think it's a voicemail or something like that.
You mentioned repeat caller, so is there caller ID?
So here's the thing. So I believe there is caller ID, but as you know, cell phones doesn't always show up. So what happens is that clinician will ask, for their name, maybe even first name. The caller does not have to give that. And they will ask for a phone number, usually under the guise of in case we get disconnected. So you know how sometimes calls drop, you're in your car, they want to be able to call back that individual. So yes, so they will have that by phone number, maybe first name only. So if that caller is a repeat caller at any point, they'll be able to pull that up by phone number. The other thing that is important to know is obviously out of confidentiality and HIPAA, these clinicians, let's say, are talking to the same individual multiple times, and they know they see a psychiatrist at a mental health center or at National Jewish or whatever their providers are, right? They cannot just reach out to that professional. They will ask that caller to sign a release, and if they call back, to let them know. So that clinician, if Joe's sort of a weekly caller, and this is what this crisis seems to always look like, what are we missing over here? That he's in recurring crisis. So they would call that professional, that clinic, that physician, the nurse practitioner, and say, listen, Joe mentioned that he signed a release. Can you verify that? And then they can have communication. Because obviously, the providers outside the crisis system that are working with consumers and their families would probably like to know what they're calling about and what's going on. Because as we know, someone's not always telling the same story. So that's an important piece. But they cannot do that without consent. So I want to just kind of emphasize that. The piece about the warm line, so it's currently operational from 9 a.m. to 11 p.m. So some of our callers, ideally, if they call after 11, they'll just get a clinician automatically, or if it's a frequent utilizer of the warm line, they can leave a message. There's a way to leave a message for the peer specialist who's coming on shift next to call them back. And sometimes the warm line is really a tool around self-care, sort of self-regulatory behavior when someone is really feeling dysregulated or unsafe. Sometimes the peer specialist can really help be grounding for those kind of consumers that don't need like some big intervention, but need something, and it's 6 o'clock at night or it's 10 o'clock at night. But they'll be deferred automatically to a clinician after 11 p.m. if they don't want to leave a message. What else can I tell you? The other piece that's important to know is that a little over 70% of the callers, their concerns, their requests are met within less than 10 minutes of that call. So that's an important piece, because when I think crisis line, back in the day, I would think, oh my God, it's always 911, it's this big rescue thing. Not the case. When you look at the data from their 4 years operating the Metro Crisis Line, And I can't imagine it's going to be all that different. But almost a little over 70% of those callers' needs are met in less than 10 minutes on the phone, which means a little under 30% could be 911, could be a mobile crisis dispatch, could be something else, right? CPS, who knows? So that's an important thing to remember. The other piece also is that nowhere in the media campaign, on the website, or in any of my like boots on the ground trying to spread the word, is there ever any description of what a crisis is? Because every single one of us in here could say, this is what my life has looked like when I've been in crisis. Okay, so we don't define it. And what I always say to people is you do not have to be on fire to call this number, to show up at one of these locations, because then it's really hard. So we really want to tell people that if you're concerned about you're not eating and you're not sleeping, if you're concerned that your child is somehow despondent or they're smoking pot and you're not sure, don't wait. So again, crisis, as we know, is individually defined. There's not one right thing. We don't want to wait till the noose is made, till the gun is loaded, till the pills are counted. So it created, and I'm going to talk a little bit more in detail of the services, so created the statewide hotline warm line. It also wanted to look at the amount of volume that goes to ER. So after working 9 years in ER, I can tell you that is not the place to go to get behavioral health care. You get an evaluation, you may get a bridge script, but it's not really happening there. Okay, you're basically disrobed, your belongings are taken, you have a guard looking at you the whole time. And so the other piece to this system is we have to really look at trauma-informed approaches, because we do not need to perpetuate any more trauma for people that are already dealing with whatever kind of crisis they're having. And I will go out on a limb, I'm not going to say 100%, but being a clinician now for many decades, I can probably guess that for sure well over 90% of people that have been in the behavioral health system at some point, in the juvenile justice system, in the foster system, in the Department of Corrections, have some history of trauma. And we have to really think outside the box. It's not just sort of the adverse childhood trauma, like childhood sexual abuse. It is poverty, it is witnessing violence, it is having a mentally ill parent, it's having, you know, even just something like being bullied. So that can be triggering. So we really have to start thinking outside the box. Even just once being put in a police car when you're suicidal in handcuffs, or being in an ER for a prolonged period is a traumatic experience. So we really have to look at that. So the other components were the walk-in crisis centers or crisis stabilization units. We do not use the crisis stabilization unit moniker anywhere because nobody knows what that is. So we call them walk-in crisis centers. Some of the locations have crisis stabilization beds, and I'll talk about what that is, and some of them are really more of an assessment with a medical person and a licensed practitioner to kind of make an assessment like what is this, what level of care, if any level of care, is this person needing. And also for some of our regions, again, when you're thinking what the lay of the land looks like in our state, many of the contractors, there's 4, okay, so certainly 3 out of the 4 contractors that cover the western slope, the southeast, the northeast, have really increased their mobile accessibility to people. So we're talking about is clinicians showing up when someone is having a behavioral health crisis at school, at church, at the Boys and Girls Club, at the YMCA, at the summer camp, at the whatever. Okay, so we want people to call that 844 number, because when they call 911, if somebody can be with this person and make sure they're safe, we don't need 2 fire trucks, 3 squad cars, the neighbors out there with their cell phone recording all the business that's going on down the road, because that is really traumatizing as well, because that's your business. And I feel really clear that unless you want to talk about why your son's acting this way, nobody needs to know. So we really try to manage that. The other piece to my job is trying to educate people on what is really 911 and what's not. So we absolutely know that some people will call 911 no matter what. We absolutely know that. And when I worked at university, Aurora EMS put together a list of 46 residents that they identified as sort of abusers of the 911 system. The top 10, I know all of them, because they didn't know what else to do. And these are fairly traumatized, folks that have really a hard time self-regulating at all despite tools or being connected, and so they would call 911. And most of the time when they'd come to that emergency department, there wasn't really an acute medical or psychiatric issue. One of the women in 1 year spent $1.4 million of Medicaid money with her crises. But I will say, for her, her crises were sick cat, I had a fight with my dad, and we need to really honor that that's where she's at. That's why something like the Warm Line would be a really good tool for her. Rarely was she admitted either medically or psychiatrically. She just needed to come in a few hours with one of us fabulous social workers, right? And we'd sort of help ground her, do whatever we could to kind of piecemeal together that she could go home. So enhanced mobile crisis, also with unmarked fleet vehicles. And I say that because, again, in sort of looking at decreasing trauma and the traumatic experience of having any kind of crisis, we don't need big marked cars with any logo saying, hey, you know, you're having something, call us. They're unmarked, and oftentimes the mobile clinicians will be able to transport if it's safe. So here's the thing, we don't want that mobile clinician or peer specialist to go out if it's at all an unsafe place. So they can have police curbside or porch side is how I like to say, but we don't need 3 squads and 2 fire trucks with a lot of bells and whistles. So we want to make sure that mobile clinician is safe. And if there's a concern around dispatching a mobile, they would probably send law enforcement, just if the kiddo's out of control or throwing something, you're just not sure. Also, respite services. Respite services mean something different in crisis response than it does in the world of developmental disability, intellectual disability world. So crisis here is basically peer or paraprofessionally managed with clinical case management oversight. So somebody that goes into respite will need to have some ability to talk about what happened for them. And they also, I always give this example, they have to be able to follow house rules like no smoking in bed. Okay, and I know that sounds silly, but you have to have some understanding of that. So there's always the question when I've presented to CAN-DO or some of the other, you know, the DD Council is, well, what about someone that is just really dysregulated at home? If that person has the ability to engage, follow house rules, respite should be fine. Otherwise, is a crisis bed a better choice? So you have to be able to understand why you're being sent to respite, and you have to be a voluntary consumer. You cannot be on a mental health hold in a respite setting. And what I can tell you also is that all the contractors that are providing the brick and mortar sites really are trying to support that child or adolescent being at home with in-home respite services. So, you know, unless it is obviously unsafe, you know, there's some crazy stuff going on, you know, in the backyard or, you know, whatever. We want to make sure that child is safe with parent, guardian, relative, whatever. If it's not, obviously they would take them out of the home. But we want to make sure that for that child or adolescent, it is important whenever possible to keep them at home with in-home respite support. Yes?
Is the respite only child and adolescent?
No, it's all.
Oh, okay.
It is all. And it's a referred only service. So if you look at the website, we have consumer facing services, which is obviously the hotline, and these locations. But what has to be referred out is a mobile dispatch and also respite. So we nowhere on the website give the addresses of respite services. If I ran a respite facility, I would not want that, because I don't need to be showing up with my 14-year-old like, here, help me. So it has to be rooted through a crisis services clinician. They have to do an assessment and decide that respite is the appropriate level of care.
And they do that assessment over the phone?
They can, not over the phone. So either they would dispatch a mobile clinician if it's indicated, or if you're living close within a vicinity and you can get the person that's having the behavioral health issue to that location, they can assess them there as well. And I don't encourage, like if somebody is really combative or not wanting to go, do not put that person in the car. You know, we don't want that, because that just creates a bigger liability for that family member or friend or who's ever driving. So, but yes, but you would call the 844 number and talk to the clinician and say, listen, I have my brother here. I can put him on the phone, but he's intoxicated. He has a history of a head injury, and he's been drinking. And his wife just left, and he's really upset, and he's saying stuff about suicide. I'm fine to be with him here for a little bit. Is there a way to get someone out? So they'll ask a few more questions. The other thing to keep in mind is urban response for a mobile dispatch is 1 hour or less. Rural and frontier, it's 2 hours or less. Not ideal. but we know that's what we have right now. So maybe the next sort of fiscal go around, I mean, things are pretty much set for 15, 16, but maybe 16, 17, as we look at what are the needs in the state. Can we get more mobile clinicians? Is respite more needed? Do we need less of something? So the contractors can decide what to do with that funding. The state did not dictate you have to have 18 of these and 6 of these and buy 4 of these, right? So each, because the regions are different, and that's what I want to say, is you have to be really mindful and kind of honor that they all have to do the same thing, but they do it a little bit different. You know, again, considering what your population is, how spread out things are. But I can tell you that certainly on the Western Slope, what they've done is they've put satellite mobile clinicians so they can do a 2-hour or less response time. And obviously we know that like a blizzard is going to maybe change that. But again, the question, when that caller makes that call to the 844 number, you know, if they're okay staying with whoever it is that's having a crisis, if that feels okay, then it doesn't need to be 911. But again, that is going to be part of the process of educating what is 911 and when can I sit with this person. So a good example, I will tell you, I also welcome feedback. My email is available. I want to hear good stories, but we also need to hear grievances. So I'm the carrier of that as well, because we want to be able to say this is not okay. If I'm taking my son to a walk-in center and I'm waiting 3 hours, I'm going to the ER. Not going to do that. So we really want to look at access, how long someone is waiting, and are they engaged? Can they get engaged? So recently I heard a story from the School Safety Resource Center. So historically, outside of Denver, because Denver's had mobile crisis, but let's say it's somewhere else. A kiddo comes to the school social worker, school psychologist, and is feeling unsafe or says, I have some suicidal thoughts. Typically that would be 911. And then it would be hold ER, hold ER. Police come, hold ER. And then children's is on divert, so they end up in adult ER, like university. And this kid is scared, maybe we call the parents are on their way. So recently, they called the 844 number. They were able to talk to the school counselor. They dispatched a mobile clinician. By the time the mobile clinician got there, one of the parents was there as well. And they were able to sort of problem solve, assess that kiddo, and the child was able to go home. So there were no fire trucks at school. There was no, right, all that kind of the dog and pony stuff that happens when you call 911. And it was a very good outcome. They were able to figure out what kind of support this family and this child needed and what was going on with that kiddo. It was really, that was a good thing. So, there's a couple things on here. So I've talked about peer support. So peer specialists are hired staffers in all parts of this crisis service delivery system. The other thing that I don't have on here is the trauma-informed approach. And all the contractors have been required to provide trauma-informed care training to all their staff, from their nurses to their peer specialists, their unlicensed, their licensed clinician. Everyone has to be really mindful. And so again, trying to decrease trips to the ER or trips to jail. I mean, this system, the crisis stabilization beds and enhanced mobile was really set up to get some of those folks out of jail and out of the ER. I know in Summit County, the sheriff is tired of taking people with behavioral health problems to jail. It's not treatment. So we also know that Summit County is closer to Lakewood than going to Grand Junction. So the other thing to keep in mind, there's not a catchment area. Okay, you can have Adams County Medicaid and be in some sort of crisis in Summit County. You don't have to go to Adams. I mean, it's different. So our clinicians, it's a very different mindset. We don't care where your Medicaid originates. If you have Kaiser, it doesn't matter. So the other piece that is going to be important, and this is again a huge shift, is for a crisis stabilization admission, pre-authorization is not required, and I just want to say that. So we don't say free, because free is confusing. We had free around the phone, and somebody thought all the services were free. So the way the laws are written around, especially commercial insurance providers, nothing's free. So all the contractors have been required to do some back billing. So if I have Kaiser and I go have an evaluation and I get admitted, I will likely have a co-payment similar to my kidney stone in the ER. And I'm not admitted, I get Toradol in a sieve and go home. Okay, so there's no way to take that away right now. It's illegal. So we've talked about that a little bit. Ideally, we would love this all to be free, but that's just not the way it works. So each contractor has an amount of money to cover people that are uninsured, underinsured, undocumented, and need crisis stabilization. So it's a different process than calling BHI to get a pre-authorization to go to Highlands or to get a pre-authorization to go to an ATU. So crisis stabilization beds are very unique in that way because there is funding to these contractors to pay for that. So a very difficult shift for the clinicians that are on the front line because we're so used to getting pre-auth, 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 whether it's Aetna or Medicaid or whoever. So nowhere does it say free on the website. It just says toll-free around the phone number. But if people ask you, you know, if you're taking someone or you're referring someone to go to the walk-in center and they'll say, what if I can't pay for this? Say, you know what, they're going to assess you and see what you need regardless of your ability to pay. And I know that's vague, but we want people to go. We don't want they're not being able to pay something if there is a co-payment eventually to not go get their needs met. Yes?
So it sounds like there's opportunities for payment plans.
I don't know that. That's a good question. My guess is if that currently exists at some mental health centers, I assume that it does, then why would it be different? So, but I don't know that. That's a very good question around payment plans. All right, so yeah, this was the appropriation, and that's going to continue again, obviously, with changes in leadership and budget cuts, but for now, we're good with that. So this is what I was talking about earlier. Something to remember is that when you live outside the I-25 corridor in these 7 counties, right up and down, you're getting behavioral health care, federally qualified health centers, primary care clinics, your OBGYN, you know, and I always say to people, if you have a broken ankle, you're not going to a dentist. Yes, your OBGYN can start you on Lexapro, but it's not their area of expertise. And I don't say that to be facetious because we are just flooded with people that need some sort of behavioral health care, but you would never go to a dentist if you have a fractured ankle. So I really encourage people to get connected. And part of this crisis response, at least if somebody shows up in this system, they're supposed to be doing very much sort of aggressive case management to make sure that people kind of get to where they need to go next. Also the utilization of peers. From an ER, I would be told, I can see this person at this mental health center, but they need to bring $30. It's not going to happen. I have no way to follow up. I have no way to get them there the next day. So really, if someone is admitted to a crisis bed or a respite bed, really the goal of case management is to figure out not only what is this crisis, because if we don't address this, they're going to keep showing up here, but how do they get to where they need to go next? Because that's really the key, and not creating this sort of crisis loop for folks. We talked about that. Yeah, so this is what we also know: rural health clinics, school-based health centers. Also in some of the federally qualified health centers, they do have an integrated behavioral health care piece. It's not regulated anyway. Some maybe do more than others, but many of them have some level of integration of physical health, mental health. We know that that all goes together. All right. So this is what came out of the report in 13. So we knew at that time that 3 out of 5 Coloradans were in need of some sort of mental health or substance abuse care. That was over 1.5 million people. Less than a third got adequate care. So what's happening to the rest of them? And so it's supposed to be 1 in 12. I think it's 1 in 12, not 1 in 2, have a severe need. Is that 1 in 2? Well, I wonder if that's a typo, but anyways. So, and this is what I mentioned earlier, we certainly have more in the last decade, more licensed clinicians, but not enough that want to deal with polytrauma, dual diagnosis, co-occurring disorders, developmental disability, TBI. And this is the other piece that is disheartening. So what happens when you live between Pueblo and Alamosa? So almost 90% of child psychiatrists are in the I-25 corridor, right? And then about a little over 80% of adult practicing psychiatrists are in the I-25 corridor. So how do you get that kind of psychiatric need and ongoing care to people that do live between Pueblo and Alamosa? So the contractors have talked about utilizing telemedicine and then trying to figure out who's appropriate for telemedicine. right? Evaluating someone for the first time and initiating a hold, not really appropriate, probably. But if someone is stable, if they're in a stable living environment, they have a support system, telemedicine may be a really key way to keep someone on medication and in some type of treatment. So, do you have a question?
I'll wait.
Okay. So this is always daunting to me. So in 2012, there was a significant spike in completed suicides in the state of Colorado. It was not quite 16%. There were 1,053 completed suicides that year. Again, reason sort of unknown. Not everyone leaves a note and says this is exactly why, okay? In 13, it went down a little bit, but not statistically significant. It went down to 1,004. But Colorado always has consistently ranked in the top 10 in the country of completed suicides.
From the bottom 48 of them.
Right, exactly, and the funding, right. And this is not new. This is not new information by any means. So this is what I always find fascinating. So the number of suicide deaths in 2013 exceeded the number of all these things. Yet the funding for innovative treatment, for more sort of extended loop around treatment is not great.
What's MVA?
Motor vehicle accidents. And if you look at homicide, you know, the news is always filled with something. It's not as many as one would think. And I don't mean to diminish homicide's a terrible thing, but so in 2012, suicide was the leading cause of death for ages 10 to 34. In 2012. In 13, they changed the parameters. It was the second leading cause of death for kids between 10 and young adults to 24. So we clearly know that that group, what is going on with our children, transitional age youth, and young adults. So the state hired Cactus Marketing, received the award to do the media campaign, and this is one of the sort of bucket groups that we need to start addressing next fiscal go around, as far as how do we reach out to this group, to the families of these young children and the transition age youth that are in high school, leaving home, maybe a little older, living at home. We need to figure that out. So this is what came up with. I mentioned this earlier. There were actually 17 different crisis numbers across the state of Colorado. This is also significant. So I've only worked in the state 10 years. I came at the end of '04. So if you think about it, over the last 10 years, the bed capacity of locked, secured, inpatient psychiatric beds has diminished significantly. Units have closed everywhere. I know universities' unit closed. These tend to not be very profitable, and I don't mean to be however that sounds, but they're not profitable. So Fort Logan has lost beds for children and adolescents. We lost Haven, closed a geriatric facility. What I can tell you is at the end of 15, there's going to be a new 92-bed locked psychiatric facility going up in, is it Johnstown? It's not Jonestown. Jonestown is the, it's Johnstown, thank you. So that will be going up. I believe it'll be opening at the end of, I think Peakview, the group that has Peakview, it's that facility, correct? But we've lost a lot of beds. And again, if you look at the average length of stay, if someone is staying 3 to 5 days, is that really making a difference? So with the crisis beds, and I'll talk about the sort of parameters of that, it is sort of a hospital alternative. So this is what we were saying earlier, but also we know that rural suicide rates tend to be higher than urban. And again, the guess might be access. It's because of access. Maybe so, but is it also the type of individual that might live on the land? You know, are they more isolated? Not just from access to care, but is it even going to be something that they would seek care for? So we need to take a look at that as well. Let me just go back before I talk more specifically about some of the services. The other thing that we know, so out of last year's completed suicides, we know that, was it 77% of those were men? So we know that more men complete, more women attempt. So that is just kind of, even if you look at nationwide data, that is typically true. Men choose firearms, most common, with hanging second and poisoning and overdose third. Women choose poisoning or overdose, hanging, and then firearms. So, you know, and that, again, probably not new to many of you. So more men complete, more women attempt. So out of those completed suicides, 77% were men. There's also a correlate that was found with states that have high gun ownership and completed suicides with firearms. I know that doesn't surprise anyone either. Yeah.
Sorry. That's 7% of men. Does that also include the adolescent? That's 70% boys?
Male, yes.
Wow.
Yes. Yeah. And you know, in some ways, I don't have this slide here, but if you look at counties like Pitkin, Summit, Eagle, 2 or 3 times higher rates of completed suicides than most of the country, and certainly in other counties in the state of Colorado. So what that means is that, and this is a little bit gruesome, but similar to the Golden Gate Bridge being sort of a suicide destination, going to the mountains is as well. Because where the person is declared is where they get that number. It doesn't matter where they reside. So it is the county where that person dies so we do have to look at that as well. Doesn't mean that people in Aspen aren't killing themselves. It just means that people go sometimes to the mountains to do that. So, any questions? I know I've rambled. Yes, Liz, of course.
I have a lot. I'm sorry.
Okay.
Okay. So, do you have an idea of the average length of time the phone calls take?
Yes. So less than 10 minutes.
Okay.
Less than 10 minutes. So the national average is, I believe, a hair over 10 minutes. And so when Metro Crisis replied to the RFP, they showed that data, and they manage it in under 10 minutes.
Okay. And I have talked with them because they're right
Yes.
over here in this
Yes.
building. One thing he mentioned was follow-up calls.
Yes, let me talk about that.
Okay.
That's a really good question. So unlike being in an ER where I can't follow up with someone, the clinicians, with the consent of the caller, are able to call back. So if you're a mom calling because something is going on with your kid, and you tell this clinician, this is what I'm seeing, and I want to take him somewhere, I'm not sure where to start. Those clinicians can kind of help navigate. I believe they have a 35,000 provider directory that they hire and employ, I want to say 3 to 5 people to manage that. It's a really big job. So they regularly find out, is the information correct? Do you still exist, right? I mean, I refer people, it's like, oh my God, you're not even there anymore. So they have ongoing staffing to manage that directory. So they do have the ability to call back, and sometimes there's multiple callbacks. Just, you know, the person can say, you know what, this referral didn't work, they're not taking anyone, is there another group that I might try? They can do that, but it has to be with the caller's consent.
Okay. So for us as staff, I guess I got a little bit confused when somebody mentioned the national suicide number.
Yeah.
We've actually been in situations where we've just transferred somebody automatically, and I think what we want to do moving forward, and we'll train everybody, is to call the number and then conference call the person and hand off.
Absolutely, and that's what we do at OBH. So I will tell you, we get a lot of calls as well. Not often, like active suicide in progress at all, but certainly someone that needs some help. So what used to happen in OBH, in that 150-year-old building, that the admin that would be answering the phone would run around 3-4 floors of that building looking for an available clinician. Not a good use of time, and not their area of expertise. They don't need to do a suicide screen. So right now, so I've been working with support staff to make sure that they can get the person's name. If you can always get the caller's name, to then say, when the hotline answers, say, listen, this is Mary from OBH. I have Bob on the phone, and he is needing to talk to someone. Can you take the call? And they'd be like, sure. Also, if you can get the phone number, because sometimes, you know, when you do that conference call thing, it drops. So always first name, at least, if you can, and the phone number. But yes.
And should it be this number? I mean, obviously you're going to say that, because instead of like the national suicide number.
Yeah, I mean, of course it should be the local number, because the national number is warehoused in multiple places, and I believe Metro Crisis, I want to say one of their venues of revenue is also answering maybe National Lifeline, whatever, but sure, use the local number. Absolutely.
Do you have an idea of percentage of calls that are repeat calls?
I don't. Okay. That would be a really good question if you wanted to know that, something that Bev's group could likely provide. Okay. Yeah.
Okay, I'm sorry.
No, that's all right. Okay, So we talked about this. So as I mentioned, the hotline went live August 1st, and the hotline warm line went live August 1st. Again, we want also for first responders, law enforcement to use the hotline as a consult. So when they show up on scene, it's not automatic hold ER. It's like, let's do an assessment. If they're not sure, we want them to call the hotline and say, listen, we have Bob here, and we know Bob for years, and he looks like he hasn't gotten a shot, and he doesn't look intoxicated, but Bob has necrotic toes because he doesn't manage his diabetes. That is a medical issue. So that's the other thing to keep in mind. Acute or potentially acute medical issues should not go to these 24/7 walk-in locations. Yes, they have a nurse, a PA, an advanced practice nurse. But even though someone has mental illness or someone is intoxicated, doesn't automatically like exclude them, right? Because if Bob, even though we know Bob has history of schizophrenia and severe diabetes, if his toes are necrotic, he needs a surgery consult. He doesn't need to be on a hold. He does not need to be on a hold. People that have done an overdose and there's clearly an ingestion, and likely they'll have to go to an ICU, intubated people don't need to be on a mental health hold. So again, that's part of this education of what is the appropriate location for someone. Obviously, acute medical needs still have to go to an ER. Combative people that may need emergency medication or restraints, even for a period of time, probably need to go to an ER. These locations will not have seclusion and restraint. And the other thing I want to say, unlike a locked psychiatric facility or an ATU, so like Bridge House, Lighthouse, they are locked settings. These locations are secured. I didn't know there was a difference until I was sort of shocked to find out that secured didn't mean locked. It means 30-second egress. So if someone is on a mental health hold at a crisis stabilization unit and they figure out about the door, they could potentially elope. That means they have to call police to say, listen, this is what he looks like. He's running down Santa Fe. Okay, so they are not locked, they are secured. So there's also going to be an assessment of who is appropriate for a secured setting versus a locked setting. And so each location is going to have to assess that, also to look at what's going on in the milieu. So crisis stabilization beds, what that means is someone can be there for 1 to 5 days. So a consumer can be in a CSU bed for 1 to 5 days. Remember, there's not a pre-authorization necessary. There will likely be back billing because the contractors have to do that. So they can be voluntary here, or they can be on a mental health hold. All the CSUs have to be 2765 designated, which just means they have to follow the rules and statute about patients' rights and grievances and access to all sorts of things. Okay, so there is some state oversight and some technical support around making sure that consumers have their rights and that those facilities are operating with quality care. So it protects the consumer, protects the facility. So 1 to 5 days, they will see a psychiatrist within the first 24 hours, usually less. They will have a brief medical screen. So what's happening, unfortunately, at some of the locations, because the licensure of some of these places, they don't have stock meds yet, which means you need insulin, you need a little bit of high blood pressure medication, you probably have to go to an ER. So right now again, it's 90 days old, we're trying to figure that out, but the hope is that once the pharmacy board and all that stuff gets sorted out, they will have stock meds for some basic health issues. They will also have stock meds of things like benzos, some emergency psychiatric meds, that kind of stuff. So 1 to 5 days, hold, not a hold. And then so the question, yes?
I'm sorry, I was just thinking,
No.
for those stock meds, would they also be able to get like HIV and AIDS medication as well?
I doubt they're going to have HIV meds. Well, you know what, I can honestly say, I don't know, but that is typically not a stock med. When I think of stock meds, I think of some basic, like maybe even antibiotic, just some basic things. If someone is on HIV meds, the hope is that someone could bring them.
Right. That was going to be my question.
Yeah.
Can they bring their own meds?
So some places, some places they can. They cannot dispense their own meds because they have to follow the double locked doors of meds.
Right.
But the other piece is if it was Mary's respite or Mary's stabilization unit, how do you really know? Because I'm not a pharmacist. Are those really the meds that they are in that bottle? Like, how do I know that? So some places are absolutely saying that's fine. For liability, I would never do it. So But with that said, every place has to decide what sort of risk or liability they're going to take. But if someone is on HIV meds or anti-transplant rejection meds and all sorts of stuff, the hope is that there's somebody in their life that can bring them those meds, because those will likely not be stock meds. So they're going to have case management here. There will be groups. There's peer specialists that will work with the consumer once they're in a crisis stabilization bed. And again, the question is, what if they're not ready to go home? So what I always said when I worked in the ER, the question that we had to ask ourselves was always, what is preventing this person from being able to go home? What is it about whatever that situation is why they can't go home? So these clinicians have to ask this every kind of step of the way. What is still preventing this person from being home? Is it there's active symptoms? Is it the unsafe home environment? Is it they're still feeling suicidal? What is it, right? So they will have psychiatric care here. It is a milieu setting. People eat together. But again, it's secured, not locked. So it has to be the kind of consumer that could be in that sort of setting.
And where are these beds?
So if I don't think, I could pull up the website actually, I could pull it up.
Are they within other hospitals?
No. So here's an example. So Grand Junction, their CSU is next to their psychiatric hospital right there, but it's a separate facility with a separate licensure. So these CSUs, most of them are licensed as community clinics through the health department, because we do not have a specific license for them, which we totally need, right? But we don't. So I know. So working with licensing in the health department, so they're licensed as a community clinic with a few waivers, because they're not going to do pelvic exams and infusions and all sorts of things. So they have a waiver because those licenses typically allow 3 days of OBS. They get a pass so they can do 5. So it just allows, but then it's also looking at, again, with the Board of Pharmacy, making sure there's stock meds available and those sort of things. Some of them are the ATU in Pueblo, the acute treatment unit in Pueblo, the acute treatment unit in Colorado Springs are being used as the CSU. So they're licensed as an ATU, so they do have stock meds and an emergency kit, and they're locked. ATUs are locked. But they're being utilized as a CSU down there. And I also think Fort Collins is opening up a CSU March or April, so very soon, but they have, their ATU is also currently being used as a CSU. And for kids, again, there's not child and adolescent CSUs, except sort of in the I-25. There's one at Jeff Hills, just on Potomac. So they have a wing that is separate from the residential. They're licensed as an RCCF, residential child care facility, so they're residential treatment, but the CSU is separate, with a separate license and separate oversight. So also New Vista on Zhang Street, I think, up in Lakewood, they also have a CSU piece to their program. So Denver Metro has access to that type of intervention for children and adolescents. So when you go west, they use Hilltop. When you go south, they use, they might have to go, because there's nothing in between, they might have to hospitalize a kiddo. So again, if there's no way to keep that child or adolescent at home with in-home support, then if that child needs a higher level of care and there's not a CSU, they would have to go inpatient, which we know is really traumatic anyways. Any questions about, no? Yes?
And the respites too, like where are those?
Right, so they're all over, and I don't know where they all are. We have a list.
How are they licensed? Are they,
Yeah, so it depends on what it is. Sometimes it's through, like in the South, they use special kids, special families for respite, so they're sometimes home-based. Sometimes they can be facility-based. It really depends on what's available in the region. And that is a whole thing waiting to unfold. Like, we're just not really sure. I know the Western Slope, the CEO of the group that got the contract, she really feels like respite is going to be something they're going to need to do more of. Probably less sort of acute, high-intensity CSU, but likely more respite. So that is sort of a wait-and-see kind of thing to see what happens there. What else can I tell you here? So they see a psychiatrist, there will be a nurse on site. Eventually they will have stock meds, hopefully, to be able to manage all sorts of things. And if the person is not ready to leave after the 5 days, for whatever reason, the question has come up sometimes in presentations, are they able to go to respite? The answer is yes. Again, it's a clinical decision. So referral to respite has to come from a crisis services clinician. Yes?
The CSUs, those existed prior to this bill, is that correct?
No.
Okay.
Yeah.
So the 25 million supports those as well?
Yes, yes. So the 25.5 million that was appropriated for this crisis response system, so the hotline got, let's say, 2.7, I'm not quite sure, but I think something like that. The Western Slope, Northeast, and Southeast probably got 4 point something, and then they combined kind of the Denver Metro, they got 8 point something, just because of they chunked together a lot of counties. And again, the state did not specify what you had to do with that money. You had to do obviously a proposal and a budget and say, you know, we need 5 fleet vehicles and we need this many mobile clinicians. The regions don't look alike as far as how they allocated their own funding, so we didn't dictate that. Yeah. Again, so in-home respite, different than when you think of respite for folks with developmental or intellectual disabilities, because these are peer and paraprofessionally managed. Folks that are referred there have to be able to follow some house rules and be able to talk about really what's happened and what's destabilized them in some way. Because there's clinical case management oversight, but it's not a secured facility. So if someone needs a secured facility or staff involvement pretty intensely, respite's not the answer. I think. So these places went live on December 1st. Nobody had to submit data until the 31st, so we're just now getting in. We have January data. We'll have February data pretty soon. And again, it's just a brand new thing. We have lots of education to do around just who's supposed to be doing what. And so I imagine there's going to be questions, problems, hopefully some good things as well. So I guess the only other piece that is going to be important for this group is, besides not needing a pre-authorization, one of the things we are working with clinicians very hard on is someone doesn't have to have a big fat DSM diagnosis. Obviously the axes got dispersed. I think May is the window after 2 years when nobody's using axes after May. So you don't have to have one of those big diagnoses because we're not needing authorization. So what typically happens in the ER or when referring someone, especially with head trauma, TBI, that's medical. Oy. So nobody, like anybody with a medical thing, it's medical. So if somebody has a behavioral health crisis, yes, they will formulate a diagnosis, but that cannot be the conclusionary or exclusionary reason that someone can't go. If someone only has a substance use problem, and the example I always give, I'm here on holiday in Summit County, I go to the pot shop and I eat way too much, right? Because a serving is the size of a pinky, I eat the whole thing. And I have tremendous anxiety. I'm hallucinating. My friends call that number, they take me somewhere, I get to be treated. Okay? I don't need a big DSM diagnosis, and I can't be turned away because it's drug related, it's pot related. The only issue is going to be, is there a medical concern? So obviously someone who is severely alcohol intoxicated, is there concern about complicated withdrawal, DTs, sort of the cardiac piece, so they may need some monitoring in a banana bag, but that's not a reason to exclude someone. If I'm suicidal and I use pot every day, I still get to be treated for my crisis. Yes?
You know, it used to be that people really didn't want to be committed anywhere for mental health issues because it sort of followed them.
Yes.
Does using this service follow people?
That's a good question. I can tell you is I wish actually we had one big electronic health record that we just would swipe a card and be like, oh, you were last seen 3 months ago here, and oh, these are your meds and this is updated. We don't have that. Again, similar to like how regions have to all do the same thing, they do it a little bit different. How it follows you, I guess the consumer would have to say, listen, I was in a CSU over on Victor Street 2 months ago. The electronic health records are not the same for these places. What I can say, the Denver Metro, the Community Crisis Connection, which is the group that received the award to do the 7-county area, they're working off of a similar, it's called TIER, so they're working off a similar electronic health record. There's a lot of glitches. So they talked about, I mean, the state has talked about what if people got together and did one. The cost is significant and the amount of work to create this one kind of thing. So does it follow you? I don't know what, like, do you have to say, you know, it's probably similar to being in an ER or saying, do you have to say they're not shared with schools or your employer, you know?
But some of that may follow if you then bill to your private insurance or whatever your insurance is, right?
Yeah, so yeah, that's a good point. So because they're required to do some back billing, like I always use Kaiser an example, and it was for a crisis evaluation. I mean, again, if we're talking about integrated care of sort of physical health and behavioral health, maybe that'll get that individual to talk to their physician, whether it's at Kaiser or Aetna, because we want to compartmentalize, and I don't want you to know that I'm having marital issues, or I don't want you to know that I have debilitating anxiety, so I'm going to go get meds here, but I don't want you to know. And again, part of that is the stigma. You know, one of the things that we're trying to look at is our languaging around this system. We don't say mental health. I mean, because the word mental for people that are not embedded in this care system, I don't want to be mental, I don't want to be psycho, I don't want to be crazy. I mean, I grew up in the days where Sybil, right, that movie Sybil, that's to me was, oh, that is, she's crazy, right? So I think, again, people that are not in some way involved, either because of family or because you're a provider in some way, whatever, I don't think that way. I don't think mental, schizo, crazy. But if you look at the kind of average consumer, I'm not like that. I'm not mental. And so again, this is going to be educating and looking at the stigma. So hence we're trying to really look at, again, that languaging and how are we spreading the word. So we're saying behavioral health, and we're going to have to explain that. We're going to talk about mental health issues, and we say things like when you're anxiety, you're really angry, and because even people don't need to know the big diagnoses. They know that they're feeling mad, or they're really been sad, and I don't feel right. So again, really meeting that consumer where they're at, but so we don't say mental illness or anything like that. And I
said that too.
Well, but I mean, you know, what we know is that people would rather have, and I always use vets. Did I already say this about the vets? But so I went to a fabulous TBI thing at university back in September, and one of the carrots I took away is it is clear that vets would rather have a TBI than a PTSD. But we all know in here they go together, along with maybe a little alcohol abuse, probably some relationship problems, whatever. So it's not the simple thing like I just have a TBI. We know there was something likely traumatic, whether it's you're in the war, or you're in a battlefield, or you were in a car accident, or you fell off a ladder at your job and you can't work anymore. So the TBI piece, I mean, I remember hearing that thinking, yeah, who wants to have PTSD? Who wants to have anxiety? Who wants to have sleep problems? Who wants to have depression? They all kind of come together. So, and so I really just, as part of my charge is really to be mindful of that. And any other questions? Yes?
My question is, basically, when you help these people on the phone, they get psychological help, maybe medication if they go.
Not on the phone, not on the phone, but they could be directed to.
That's the aim of it, the goal of crisis.
Yes,
help these people with that. Is
yes.
there any other therapeutic help for them?
Yeah, so depending on what that caller's needs are. So maybe the caller says, you know, I was on meds 20 years ago, I'm new to Colorado, I don't even know where to start. So sometimes it's connecting that caller with an organization or a provider that can help them get back on meds. Or you just lost your spouse and you're grieving and you don't want to go to your church, or that's just too much. You want to go to a group and you'd rather do it not with whatever. They can help you get connected. So really there's many reasons why people call. Referral sources for themselves, treatment for their family member, their loved one, trying to figure out how to get on Medicaid. You know, just you can imagine it's all sorts of things that are stressing someone. So yes, the idea is how do you get that person to the right place?
So how can we get into network? So we are in a unique position that we have a non-invasive deep brain stimulation, which helps with any brain injury, with each disorder, with mental health problems. So how can we get in a network with that? It's a proactive treatment.
So you mean as a referral source?
Yes.
Yeah, so you would get in touch with Sherry Skelding or Bev Marquez over at Rocky Mountain Crisis Partners in one building over, because I have had people call and say, listen, I'm a provider, can you add me to that? They would be happy to add you to that directory. And as Liz said, Judy Detmar, we're trying to figure out some really annual training for people, because questioning is a little bit different. And if someone doesn't say, yeah, I have a head injury, or you know, and if you're not, what questions are you asking to try to get that information? So, yes.
And what I would say is we are kind of like a single entry point, and so we have a resource directory, and I think one thing that we really want to achieve with the trainings is also resources. I know we're in the Rocky Mountain Crisis Partners.
You are, okay.
But you know, if somebody gets referred to us and they're in the Springs, or you know, they need a particular resource, we house that, and so we can help triage from that point. And I think that's kind of the hope, is that when we do these trainings, it's not only, you know, the education for the clinicians, but also here's a good phone number to call for resources.
Yes.
And we can help take it from there.
That's awesome.
So,
yeah.
Hopefully.
Yeah.
So be in our resource directory, and then we can help triage
Yeah.
you guys.
Exactly. Anything else? Any?
Oh, I did have one more question.
Yeah.
You were talking about how the data is kind of disconnected because they're using different, so how?
So the data markers are not different,
Okay.
but as you know, I don't know if you guys are familiar with CSTAT. Okay, it's basically for all the offices in the Department of Human Services that we have to report stuff to this next level of leadership. So the data markers, we had 90 days to put all this into effect. That's the other thing. Once the contracts were signed, 90 days. That is a really short amount of time to come up with brand new data systems, figuring out electronic health records, building things. Like it was a very brief time frame. So the data markers, I'm not sure, reflect exactly what I'd like to know, which is, you know, how many people are showing up, who's getting admitted to CSU, how many people are going to respite, how many people are you kind of helping right then as a walk-in and sending home. I imagine this next contract go around, my hope is that we look at some of that, like is there other information that would be most helpful, that is just some of the more nuts and bolts stuff. So they all have to report on the same thing.
Okay, but they collect it differently.
A little bit different, yeah. Yes.
Is the hotline prepared to answer calls from that 10 to 24, the minors? So if you had a 10-year-old, 12-year-old, we see a lot of younger sports athletes.
Yeah.
They come in, I have flyers where they could pick one up.
Yeah.
Is the hotline prepared to talk with a child, a teenager who doesn't have
Sure. What I will say is there's also specific lines for teens and kids. And I don't know, you know, like the teen talk line and things like that, but sure. It doesn't, yeah. I mean, anybody can call. As far as then referring someone for treatment, you know, you have to be 15, but certainly anybody can call. Yeah. And I imagine that caller will say, can we talk to your parent, or is there a guardian there, or who are you living with? But the what?
So what if the parent's the abuser?
Well, that's a whole nother thing. I mean, if the child calls the crisis line to say I'm being beaten, they're likely going to dispatch 911 and get child protection involved, for sure. But I mean, or my guess is they wouldn't call the hotline, they'll just call 911. I mean, they know enough to call 911. If they're being harmed and that they have enough, they would call 911. They don't need to go the sort of, but if they do, sure. Yeah.
Well, thank you so much.
Okay, thank you very much. Yay.